Well, good morning, everybody. Let's get started. Thank you for joining us for the Chickasaw Healthy Eating Environments Research Study, our CHEERS webinar series. My name is Cole Alec, and I'm a member of the Turtle Mountain Band of Chippewa Indians, and I am tribal liaison here at Partnerships for Native Health, which is a program at the Institute for Research and Education to Advance Community Health, also known as IREACH. In this webinar, Tori Taniguchi and Charlie Love will give a presentation on an overview of the CHEERS study. Next slide. Before the presentation begins, I'll give a brief overview of Partnerships for Native Health at IREACH and CHEERS, and then we'll finish with a question and answer. Next slide. IREACH at Washington State University challenges the status quo and advances community health through partnerships and collaboration. We conduct research with rural, Native, and Latinx populations, health networks, and populations with substance use disorders. Next slide. Our IREACH faculty belong to various colleges at Washington State University, and we partner with external collaborators at universities across the country. The Institute houses 5 primary research programs, including Partnerships for Native Health. Next slide. Partnerships for Native Health conducts community-based research and education to improve health and reduce health disparities among American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders. We do this by working with both community and academic partners in community settings. We focus on achieving health equity, community outreach and engagement, and training and education. We have over 60 partners across the country, including tribal colleges, Native organizations, tribes and universities, as well as 7 satellite centers located in Alaska, Colorado, Minnesota, New Mexico, North Carolina, Oklahoma, and Washington. Our program focuses on research topics that are important to the populations we serve. Next slide, please. CHEERS comprises several mutually reinforcing strategies to improve blood pressure control among American Indian adults with uncontrolled hypertension. Study findings, including a health economics assessment, will be used to promote policies to expand both the PACT promise for a healthy heart intervention and the establishment of brick-and-mortar grocery outlets in rural Chickasaw Nation communities. After the conclusion of this webinar, you'll be given a chance to provide feedback through an evaluation survey. A recording of this webinar and presentation slides will also be available on our website. At the end of the presentation, there will be time for a Q&A. Please submit your questions today using the Q&A box in Zoom. And now I would like to hand it over to today's presenters.
Hi, everybody. Thank you, Cole. Good morning or afternoon to everybody, depending on where you're calling from. Thank you for joining us today for this webinar. My name is Charlotte Love, and myself and Tori will be co-presenting in this webinar. Just a couple of housekeeping items. We understand there's quite a varied audience registered for today's webinar, so we've done our best to try and explain things and break down acronyms, and not just assume that everybody on this webinar is familiar with the research terms and acronyms that we like to use. So we will try and explain things as best as possible. However, if you do have a question during the webinar, feel free to pop it in either the Q&A box, which you should be able to see on your Zoom sort of panel at the bottom or top of your screen, or in the chat, and we will try and address those as we go. Otherwise, as Cole mentioned, there will be 15 minutes of Q&A at the end, so feel free to reserve your questions until that time. So yes, we are presenting about the Chickasaw Healthy Eating Environments Research Study. As Cole mentioned, it's part of the larger Native Chart Center, which is led by Dr. Deidre Buchwald and Spiro Manson. And next slide, please. Before we begin, we would just like to acknowledge some of the folks that make this work possible. First and foremost are the staff at Chickasaw Nation, who really are the boots on the ground sort of leaders of this study. And they do everything from calling participants and making appointments and following up with folks and data entry and sort of all of the really pragmatic, practical things that are required to make this program run and make sure that this study goes off without a glitch. So just wanted to acknowledge them. They have also been incredibly resilient and flexible with this study, as it's evolved a lot from when it was first written to actually what's possible now and what takes place now at the Chickasaw Nation. So they've done an amazing job to adapt to these changes and really just be open-minded and finding solutions when barriers have come up. So I just wanted to take a moment to honor and acknowledge that. And then we'd also like to acknowledge Dr. Valerie Blueberg-Jernigan, who is the principal investigator for this study, which you also might hear me refer to her as the PI in further slides. Next slide, please. So a little bit about where Tori and I work. We are at the Center for Indigenous Health Research and Policy at the Oklahoma State University Center for Health Sciences. We are located in Tulsa in Oklahoma. We are a newly established center as of January 2019, led by Dr. Valerie Blueberg-Jernigan, who, as I mentioned, is the PI of this study. And our center focuses on 3 primary areas, including reconnection, education, and training. And we work with American Indian communities across Oklahoma and other states. Our main work focuses on improving the food environment to decrease diet-related chronic health outcomes across the US. And all of our work uses a community-based participatory approach, which Tori will talk a little bit more about further on in this slide deck. Next slide, please. At our center, we have several research studies that are funded by various institutes from the National Institutes of Health, such as Thrive and FRESH and the NOSH study. And then, of course, all of these address diet-related chronic disease with various different tribal nations across Oklahoma. But the focus of today's talk is, of course, the CHEERS study. Next slide, please. So a little bit about the background and the reason that we do the work that we do. American Indians in this nation experience higher morbidity and mortality from chronic disease and associated risk factors compared to the all races population. For example, 43% of AI adults are obese. AIs are twice as likely to develop diabetes compared to non-Hispanic whites. And the prevalence of hypertension is also higher in American Indian populations compared with non-Hispanic white populations. About 35% of American Indians experience hypertension compared to almost 26% of the non-Hispanic white population. There are also significant disparities among risk factors for these diseases, such as tobacco use, physical activity, and fruit and vegetable intake. Next slide, please. So in addition to the likelihood of somebody who is American Indian contracting these diseases, unfortunately, data also shows that cardiovascular disease is more likely to be fatal in American Indians relative to other races, with mortality rates 20% higher than in the general population. 36% of American Indians with cardiovascular disease, CVD, die before age 65 versus 15% of non-Hispanic whites. Next slide, please. The data also shows that food insecurity, shown in these slides as FI, which is a term that we use in research and science environments to describe the limited availability of nutritionally adequate and safe foods, is an independent risk factor for chronic disease. So for those who aren't familiar with food insecurity, it is measured by asking different questions about how individuals and households acquire food for their home, whether there is stress about where the next meal will come from, whether they are reducing the sizes of their meals, skipping meals, or in the worst case scenario, going whole days without food. And so it's a measure that is used pretty widely now in the science. And results have found that approximately 30% of American Indian households experience some level of food insecurity, compared to 14% of non-American Indian households. So you see that American Indians are experiencing this a lot more frequently than the non-American Indian population. And food insecurity is also associated with poor food environments, which are common in American Indian communities. Many American Indian communities in the United States, especially in Oklahoma, are very rural locations. Poor food environments can be described as food deserts. So places where there are not many grocery stores, or the grocery stores that do exist in those places are either not reliable, they carry produce that is damaged or rotten because they are so far out. And then also some of our previous research has shown that grocery stores in American Indian communities have products that are priced extortionately higher than places that are not on American Indian territories. So in addition to that, in these rural sort of food environments, you also find areas that are defined as food swamps, which is a sort of newer term that describes these places that have little access to grocery stores and fresh fruits and vegetables, but they have high density of fast food chains and convenience stores. Specifically in Oklahoma, it's extremely common to drive out to these rural locations that we work in and find 2 or 3 big chain fast food restaurants, Sonic, McDonald's, whatever it is, near a convenience store, and then not a grocery store in sight. And next slide, please. And so because of this, specifically in Oklahoma, diet-related chronic disease rates and risk factors in American Indian populations are even higher than the national average American Indian population. Oklahoma is actually ranked 46th in the nation in regards to health outcomes overall. And you can see that the statistics for hypertension, obesity, overweight, and diabetes are all higher than those reported in a few slides earlier for the national American Indian populations. So Oklahoma American Indians also have low consumption of vegetables and fruits. About 20% report eating vegetables less than 1 time per day, and 46%, so almost half, are reporting eating fruit less than 1 time per day. When you compare that to the recommended daily average of 3 servings of vegetables and 2 servings of fruits per day, that disparity is quite alarming. Next slide, please. So as you can see, this work is extremely important in American Indian communities in Oklahoma. And on this slide, in case anybody is joining from internationally, you can see that Oklahoma is highlighted in green. We are a landlocked state in the Midwest of the country, and we also belong to the Southern Plains region. And this is primarily where the work of the CHEERS study takes place. Next slide, please. If we zoom in to this map of Oklahoma and the tribal jurisdictions shown, you'll see that Chickasaw Nation is in the southern part of the state, right between Choctaw Nation and then also the Kiowa, Comanche, Apache tribes. The university partners, so Tori, myself, Dr. Jernigan, and others at our center are located in Tulsa, which is located right where the Osage, Cherokee, and Creek reservations meet, due northeast from Chickasaw Nation. It is about a 2.5-hour drive, obviously depending on where you're going in Chickasaw Nation from Tulsa. Next slide, please. And this is again zooming in even further to look just at the Chickasaw Nation boundaries. There are a large number of counties within Chickasaw Nation. However, this particular research study focuses only on Pontotoc, Johnston, Carter, and Murray counties. And now I'm going to hand over to Tori, who's going to tell us some more about the study specifics, the partnership, and some of the preliminary data that we have so far about the study population. Thanks, Tori, over to you.
Thank you, Charlie. So again, my name is Tori Taniguchi, and I work as the data director for our center at Oklahoma State University. And like Charlie said, I will dive more into the CHEERS study itself. So again, CHEERS is funded, next slide, please. So CHEERS is funded by the National Institutes of Health as one of the 3 projects under Native Chart. And it's a 5-year community-based participatory research study with the purpose of improving blood pressure control among American Indian adults residing in Chickasaw Nation with uncontrolled hypertension and improving body mass index. So the outcomes of interest for the study are blood pressure and body mass index as our primary outcomes. And then we are also interested in looking at diet, so specifically vegetable and fruit consumption, physical activity, and perceived food access. So how difficult is it for participants to obtain healthy and affordable food? The design of the study is a cluster, multi-level, randomized controlled trial. And it's a multi-level study because we are targeting changes among the individual, environment, and policy components. And it's a cluster randomized trial because this intervention is randomized by groups instead of by individuals. And in this case, it was randomized on the county level. There are 4 Chickasaw Nation counties included in this study. So 2 were randomized to the intervention group and the other 2 to the control group. The total sample size in this study will be 400 participants. And the study is a 6-month intervention administered as rolling longitudinal cohorts. So we are following groups of participants in both the intervention and control groups to see if there are any changes in the study outcomes listed above from before the intervention compared to after. And the CHEERS intervention launched in June of last year. So that is when the first cohort received the intervention, and it's currently in the 4th of 5 years, so it is still ongoing. Next slide. So we used a community-based participatory approach orientation in the CHEERS study as well as our other research studies. I'm not going to read this entire definition, but community-based participatory research is an action-based research approach, and it integrates education, research, and social action to improve health and reduce health disparities, highlighting that tribes and communities are equal partners with academic and research institutions. The principles of community-based participatory research, also known as CBPR, include co-learning, long-term commitment, and mutual benefit. CBPR is especially important because many of these tribal communities have a deep-rooted mistrust for medical research, given their history of exploitation. And now actually many tribes have their own research review boards. And the approach of CBPR in improving quality of life among tribal citizens is congruent with the tribal review policies in place. So by regarding tribal nations and communities as equal partners, addressing research that incorporates community priorities, and focusing on action research that improves health, we are able to employ culturally relevant methods to reduce these health disparities in tribal communities. Next slide. So our community-based partnership with Chickasaw Nation actually started over 8 years ago with our 5-year Thrive study. In this study, we implemented a 9-month healthy retail makeover in 4 tribally owned and operated convenience stores with a focus on procurement of foods from local sources. And our Thrive study was successful in that we found an increase in availability and purchasing of vegetables and fruit. We found that almost 75% of Chickasaw participants shopped for food weekly at these convenience stores, and over half cannot afford healthy meals. So with Thrive coming to an end, we wanted to continue our partnership with Chickasaw Nation for future research. And since CHEERS is a hypertension focused study, we looked at the data from the Chickasaw Nation tribal health system and actually found that about 80% of adult patients had pre-hypertension or hypertension. And then we also found that cardiovascular disease was one of the leading causes of death in the nation. So a major priority of the nation was to continue to improve the food environment, and this aligned with our work with the CHEERS study. So our partnership for CHEERS consists of both a university and tribal principal investigator, as well as university researchers and tribal researchers from the Nutritional Services Department in Chickasaw Nation, as well as other key stakeholders. And Chickasaw Nation does have their own institutional review board, and their tribal IRB oversees all aspects of the CHEERS study. Next slide. So the specific aims of the CHEERS study target all 3 levels of environmental, individual, and policy, and they are to improve healthy food access in the community, to improve blood pressure, body mass index, diet, physical activity, and perceived food access among American Indian adults with uncontrolled hypertension. And lastly, to evaluate the effect of the documentary and multimedia manual produced from the study on tribal leaders' readiness to implement the study across all of Chickasaw Nation, as well as to other tribal communities. Next slide. So this is the conceptual model we are using for the study that integrates the multiple levels of policy, environmental, and individual, which influences behavior. So the policy factors for the study include the documentary and multimedia guide of the study's findings and changes in tribal legislation that may lead to the expansion of the CHEERS intervention that includes more healthy food purchasing of heart-healthy foods. The environmental level factors related to CHEERS include an increase in access and reduction of barriers to healthy, culturally preferred foods, and also access to the Tribal Wellness Center. And these environmental factors relate to the individual components of CHEERS, which I will get into a bit later. But these 3 levels interact directly and indirectly to influence blood pressure control among participants. Next slide. So the first aim of this study is to assess the food environment in Chickasaw Nation. And this was done by evaluating the number of food stores and types of food stores in each of the counties. And we also looked at some sociodemographic characteristics. We also looked at the different types of feeding programs that are already implemented within Chickasaw Nation so that we could identify program gaps and priorities for the tribe. And then lastly, we finalized communities that had high and low access to food for randomization for the study. And we found that the towns of Ardmore and Ada, which are located in Carter and Pontotoc County, had higher access to food programs and food stores, while Tishomingo and Sulphur, which are located in Johnston and Murray County, had lower access. Next slide. So after determining food program gaps and identifying priorities with the tribe, we wanted to increase access to healthy food in these counties in order to increase positive health outcomes in the tribe. But since some of these counties had poor food environments with low accessibility to healthy foods, university and tribal staff collaborated and decided to tailor a food program called Pack Promise, which is a program that provides participants with home-delivered food boxes. So we ran a nutrient and cost analysis to find the most economical foods that met the DASH guidelines, in which DASH stands for Dietary Approaches to Stop Hypertension, and it's designed to help treat or prevent high blood pressure and lower BMI with a high fiber and low sodium diet. So these intervention boxes contained shelf-stable food products to provide participants with a month's supply so that participants could prepare low-sodium healthy meals at home. And the food box vendor that we partnered with for this was Feed the Children, which is located in Oklahoma City, Oklahoma. So about 2 hours away from Chickasaw Nation and about 1.5 hours away from our center here in Tulsa. Next slide. So as part of the intervention and tailored to a hypertensive population, these heart healthy food boxes were developed to be shipped monthly as part of the 6-month intervention to participants right to their front door. So these food items varied each month. However, the food servings provided in the boxes were standardized to provide participants with a month's supply of fresh, dried or canned fruit, fresh or low sodium canned vegetables, unsalted nuts or beans, lentils, and canned fish. So there are 2 variations of the 6 monthly food boxes. Boxes 1, 3, and 5 have the same contents and slightly differ from boxes 2, 4, and 6. As part of the intervention, the food boxes also contained 4 $5 fresh checks worth $20 so that participants can spend on fruit and vegetables at the local farmers market. Along with food and the fresh checks, the boxes also contain healthy recipes from Get Fresh, which is a Foundation program funded by the U.S. Department of Agriculture, used to promote healthy eating habits and cooking techniques. So all the recipes were verified by a registered and licensed dietitian on the study team, just to ensure that the recipes included in the food boxes were DASH compliant. And lastly, the boxes contain educational materials that highlight a specific food group in each box. Next slide. So this is an example of what one of the recipes look like from the Get Fresh Tribal website. So we try to ensure that each recipe put into the food box corresponds to the food inside the boxes. Next slide. And then this is an example of one of the educational materials that goes into the boxes as well. So the handouts are based on the DASH diet guidelines and outline the benefits of different healthy food groups, the recommended number of servings per day, and monthly goals to help participants consume more of that food group. And then the other 5 educational handouts address seasoning without salt, fruits instead of processed sweet, nuts, seeds, and beans, lean meat, poultry and fish, and whole grains. Next slide. So AIM 2 gets more into the individual level components of the study. While participants in only the intervention group received the food boxes with the educational materials, recipes, and fresh checks, both intervention and control participants received a tribal gym membership, a Fitbit to assess walking physical activity, and access to a culturally developed phone application called AYA, which is an interactive walking app that's grounded in Chickasaw storytelling and history. Next slide. So the AYA app is unique in that it was created by Chickasaw Nation, and AYA means to go or to journey, and it allows users to unlock improved health and cultural understanding at the same time. Next slide. So each participant can choose their Chickasaw character out of these 5 characters, and each Chickasaw character has a different path or journey with different storylines. Next slide. There are 22 episodes of historical fiction that the AYA app takes participants through, depending on which Chickasaw character they chose. There are points of interest called medallions throughout the journey, and these medallions represent an important location throughout Chickasaw history. The app is also able to track step progress, and participants also can unlock Chickasaw language and words and prayers throughout their step journey, which also may be different depending on their chosen character. Next slide. So the AYA app does sync with the Fitbit to display step data, and prior to distributing Fitbits to participants, tribal staff provided in-person trainings and instruction on how to download, set up, and access the AYA app, and how to sync it with their Fitbit. Next slide. So the last aim of the CHEER study targets the policy level. So we will create a documentary and multimedia manual after completion of the study to distribute to the rest of Chickasaw Nation. This documentary will include video, photos, narratives from tribal leaders and Chickasaw families, as well as research into historical and current Chickasaw Nation dietary practices. And this multimedia manual will be web-based, and it will contain a toolkit of intervention materials using a combination of video footage, study tools, and some of the study findings. We will also conduct interviews to assess the readiness of tribal leaders in Chickasaw Nation to implement CHEERS more widely. And if the intervention appears to be successful, at informing Chickasaw policy, we will disseminate the documentary and manual to other tribal communities and measure its impact on attitudes and intentions of other tribal leaders to implement this program. Next slide. So I just went over the 3 aims of the study and kind of the components of each. So now I will talk more about the individual level methods of the study used for specific aim 2, such as recruitment, data collection, measures, and where we are currently with the study. So recruitment for Cheers began in the fall of 2018, and we are currently still in recruitment for the 3rd and final cohort. We are using multiple strategies to ensure maximum enrollment. So tribal staff are setting up recruitment booths in each of the communities included in the study, and participants are recruited through community events, health fairs, newsletters and advertisements, and at the health clinics. To be eligible for the study, participants have to meet one of 2 blood pressure criteria. So the first is participants have a self-reported previous diagnosis of hypertension by a medical professional and a systolic blood pressure measurement of 130 millimeters of mercury or higher at screening. Or for participants that do not have a self-reported previous diagnosis of hypertension by a medical professional, they have to have a systolic blood pressure measurement of 130 or higher at 2 separate screening appointments on different days. So participants that do not have a previous hypertension diagnosis are still screened, and if they have 130 or higher systolic blood pressure, they're asked to come back on another day for a second screening. And if then their blood pressure is 130 or higher again, they are eligible for the study as long as the other eligibility criteria are met. So along with the blood pressure requirements, participants are eligible if they're 18 years or older, identify as American Indian, live and plan to remain in one of the 4 counties for at least 12 months, and are not currently pregnant, or they are 6 weeks or more postpartum. And all eligible participants who agree to participate in the study, after signing a consent form, they are then scheduled for their baseline data collection visit. We are implementing this intervention in rolling longitudinal cohorts. So there are 3 total cohorts with a staggered intervention. And this approach was due to some logistical constraints involving in packaging and mailing the food boxes each month. And we are following participants in each cohort from pre-intervention to post-intervention at 2 data collection time points, so at baseline and then follow-up. Next slide. So for the individual component of the study, we are looking at different data at baseline and follow-up. For biometrics, tribal staff are measuring height, weight, blood pressure, as well as documenting any medications the participants are taking at in-person appointments. To assess diet, we are administering a 24-hour dietary recall using the ASA 24, which is a free web-based tool that enables multiple automatically coded 24-hour diet recalls. And this is done either in person or they can do it on their own using a personalized username and password. And lastly, each participant completes online surveys that ask about their health, physical activity, food environment, food availability, food security, social support, as well as other domains. And participants may do these surveys in person at their data collection visits, over the phone with a staff member, or online on their own time by using a personalized link. And each participant does receive gift cards totaling up to $120 for their participation in the data collection. Next slide. So to ensure standardized data collection, all field study staff received intensive in-person trainings to perform blood pressure measurements for data collection. So staff were trained and tested by study physicians on appropriate blood pressure measurement procedures and their ability to correctly identify cough sounds. And cough sound tests results were evaluated by a study physician, and staff needed to identify 85% or more of the sounds correctly within 2 millimeters of mercury to be certified to conduct blood pressure measurements in the field for this study. Next slide. So we currently have 268 participants consented into the CHEER study with a retention rate of about 80%, meaning that among those consented and enrolled in the study, we were able to get 80% of the participants to come back and complete their baseline data collection. So in the first cohort, we have 136 participants, 99 participants in the intervention group and 37 in the control group. And in cohort 2, we have 78 participants, so 50 of which are intervention and 28 which are control. And we are still recruiting for cohort 3, but is currently on hold due to the COVID-19 pandemic. Next slide, please. So cohort 1 completed the food box and nutrition education intervention in November of last year. Cohort 2 began the intervention in April of this year. So participants in this cohort are about to receive their third food box out of 6 in a couple of weeks. And then we did change food vendors from Feed the Children to the Regional Food Bank of Oklahoma for the second cohort, but we were able to procure almost the same food items, just with minor substitutions that still met those DASH guidelines. Next slide. So this is the baseline demographic characteristics for the 136 participants in the first cohort who completed the intervention. The mean age was 47 years old. Over 80% were female, and completed education varied. So about a quarter completed high school, some high school, or received their GED, and another 25% had some college schooling. About a quarter of the participants had an annual household income between $35,000 to $50,000, and the mean number of adults living in the household was about 2, and children under the age of 18 living in the household was about 1. Next slide. So although the first cohort has completed the intervention, since the study is still in recruitment, we do not have any results from post-intervention analyzed yet. But this table shows the health characteristics of cohort 1 before that baseline, so before they received the intervention. The mean blood pressure was 135/82, which we knew it would be elevated at baseline since participants had to have a high blood pressure to be enrolled in the study. About 80% of participants were classified as obese according to their BMI, and almost 40% reported they had diabetes. The majority of the sample were non-smokers, and 20% had no moderate or moderate physical levels of activity reported in the week they were surveyed. And the mean number of days spent walking at least 10 minutes in the week they were surveyed was about 4 days. Next slide, please. So again, since the study is still in recruitment, we do not have any outcomes analyzed at this point yet. However, this study is one of the first to use culturally relevant methods to assess a food box intervention on health outcomes and diet among American Indian adults with uncontrolled hypertension. We do expect that the CHEER study will reduce perceived barriers to healthy diet and self-efficacy for blood pressure control. We expect more improvement for all outcomes among the intervention group participants, and we expect the study will support an independent beneficial effect of the AYA app for blood pressure control. So the knowledge and results produced from this study will be disseminated to expand all of Chickasaw Nation and to other American Indian communities to assist in developing appropriate food environment interventions. And I think we have some time for any questions.
All right, opening it up for questions. We do actually have a question in the question and answer box from Sarah Eve Sarlica. Hopefully I said that right. Her question is, can you discuss why manual blood pressure measurement was used instead of using automated blood pressure monitors? And my sort of brief answer is that the manual blood pressure measurements are considered the gold standard. So for research purposes, it was decided by the methods core from the native chart group to use the more accurate, rigorous method of using the manual blood pressure measurement to get those readings. However, we actually have, I noticed, our hypertension / blood pressure expert on the line, Jason Umans. And so, Jason, do you have anything else to add to that?
No, that was a perfect answer, Charlie. Thank you.
Okay, nice. All right, are there any other questions? Okay, we have another question from Tova Wolf. Great talk / amazing study. Best wishes with it continuing after COVID. I am sorry you may have mentioned this, but what does the control group receive, gym and diet wise? So Tori, do you want to answer that question?
Sure. So the intervention group is the only group that receives those food boxes that include the food, educational materials. So the control group only receives the tribal gym membership, the Fitbit, and then access to the AYA app that syncs with their Fitbit. You're welcome.
Other questions? Actually, I guess. Oh, Jason Humans has a question from the chat. How sure will you be of post-intervention adherence to a DASH diet? Will this only be based on ASA 24? Is this good enough for total sodium and potassium? That is a good question, and Tori and I, unfortunately, are not the dietitians in this study. With the ASA 24, it is only a 24-hour recall of everything that you ate the previous day. So it is a limitation of the study for sure. That doesn't measure sort of long-term sodium and potassium intake like a urine sample would. I believe that a urine sample would be a better measure. So it's definitely something to think about for studies in the future. However, we didn't have the capacity to do urine samples with this study. So that, yes, Jason, that's definitely a limitation of this study, but, you know, kind of working within the bounds of what we have, that's the best that we could do for this situation. Hopefully that answers your question. Sarah has another question in the Q&A, and she says, ideally, if this were to become policy, how would you like to see this funded? And that's another great question. We, ideally, the tribe would take on the funding, and that is the beauty of having the health economics portion of a research study like this, because hopefully, which we don't have the results of this yet, but hopefully the results of the health economics piece would show that implementing a program like this will save your medical system or your tribal healthcare or however it is that you sort of support your tribal members with their healthcare needs. The idea is that hopefully the health economics portion would show that doing this kind of program is going to save your medical system money by reducing those health disparities. So the health economist can run calculations to show that for every tribal citizen that contracts hypertension, you know, that's going to cost the tribal healthcare system X amount of dollars. And usually, because healthcare in this country is so expensive, usually running a simple program like the CHEERS study is more cost effective than the healthcare costs. So if the program works, if you know, we see people reducing their hypertension and becoming more healthy, we can predict that that's saving the tribal healthcare systems money, and hopefully convince tribal leadership that it's a worthwhile program to invest in as sort of a preventative measure of you know, controlling people's hypertension and not having them develop diet-related comorbidities such as diabetes and cardiovascular disease further down the line. Hopefully that answers your question. And actually, we have Joy on the line as well. I saw earlier, and I don't want to put Joy on the spot if she doesn't want to be put on the spot. But Joy, do you want to talk a little bit about the tribal leadership adopting this program? I've unmuted you, but if you don't want to answer that on the spot, feel free to just pass on that. I don't know that Joy is there or wants to contribute. But anyway, hopefully that answers your question. In this particular instance, we have actually already seen interest from tribal leadership to continue the program. So that's pretty exciting. I don't see any other questions for now unless I'm missing any.
Charlie, did we want to put our emails in the chat box in case people think of something later and wanted to shoot us an email?
Yeah, that's a great idea. All right, I have just posted my email address in the chat box, and so has Tori. So if anybody has any questions that they think of, you know, later on, feel free to ping us an email, and we'll be happy to answer your questions. Oh, I think something else just popped in. The question and answer. Oh, is there anything we can do? This is from somebody who chose to be anonymous. Is there anything to do to promote, elevate, support this study and others like it? That is a great question. Tori, do you have any ideas?
I think, so the Dissemination Core of Native Chart, I think has a website for all of their hypertension studies. I'm trying to think of what it's called.
Yes, Native Chart does have a dissemination core, and oh, it says page not found. So you can follow them on sort of social media. You can also follow our center at Oklahoma State University. I will quickly grab that website and post it in the chat as well. There's a website as well as, you know, like Facebook page for both of these places. So let me try. So just sort of following those social media sites or checking the website every now and then, you can keep sort of up to date on things that are happening. We hope to have some results from the study next year, by next year. So just be on the lookout for those. when we publish results, those will be shared, links to those results will be shared on the website and Facebook pages. Oh, and
thank you, Nicole.
posted the NCHART website. Thank you, Nicole. All right, well, I am not seeing any new questions. So we will, thank you, Jason. We will hang around for about 5 more minutes if anybody else wants to ask a question. Otherwise, thank you all so much for joining our presentation today, and just sort of follow our Facebook pages and websites to follow along with results as those get published. And we really appreciate you taking the time to join us. So thank you so much.
Yes, thank you.